for this. Okay. So, edema means accumulation of excessive fluid in the interstitial space. We have normally fluid present in our interstitial fluid. From this fluid, the cells exchange the gases and get the waste out. But when there is an excessive accumulation of that fluid in the interstitial space, we call it edema. And where does this normally fluid comes from? It comes from extravasation from the blood vessels into the interstitial space. So there is a blood vessel. Outside the blood vessel is the interstitial compartment, and then you have the intracellular compartment. So around the cell is your interstitial space, and then you have the blood vessel. Hydrothorax, whenever you have accumulation of fluid in the thoracic cavity, someone has an accident, not wearing a seatbelt, not having an airbag, his chest hits the steering, there is an injury causing internal bleeding. That's a fluid as well, by the way. When it accumulates in the thorax, it's called hemothorax. If it's the water, then we call it hydrothorax. Got it? So, and how we treat it? We give a chest tube. We cut from here, intercostal space, and we put in a tube, and that tube drains all the fluid that is accumulating in the thoracic cavity. Otherwise, the expansion of the lung is very, very painful. It's that painful, the person is screaming. At the moment you put the chest tube and start draining, it starts to become better. Because this prohibits the lungs from expanding and relaxing properly, so the respiratory drive is effective. Hydropericardium, pericardial space, which is your very small space between the myocardium of the heart and this outer layer pericardium. Whenever you have a myocardial infarction, whenever you have an inflammation in the myocardium called myocarditis, it can lead to the collection of the fluid in this small cavity, and this is called hydropericardium. Similarly, in case of your abdomen, if there is an excessive accumulation of fluid in the peritoneal cavity, then it is called hydroperitoneal or ascites. We studied that in medical terminology as well. And then finally, if you have this accumulation of excess fluid in the subcutaneous tissue or in the interstitial space of all the tissues of the body, it's generalized edema. Not in one tissue, not in one area, but in the whole of the body, there is an excessive accumulation of fluid in the interstitial space, which is also called subcutaneous tissue swelling. Then that is called your anasarca. Okay? Now let's discuss this. This is important. 60% of the body weight is water. If someone is weighing 100 kilos, 60 kilos out of that is just water weight in a human being. Total amount is 40 liters. You see this big bottle you put on the dispenser is 19 liters. So 2 such bottles and 2 1-liter bottles. This is how much water we have in ourselves. 40 liters of water. And this is divided into intracellular component and extracellular component. Extracellular, outside the cell, there are 2 compartments. One is the interstitial compartment, the interstitial space, and one is your blood vessel. So out of the 40 liters, 2/3, the majority of the bulk is within our cells, intracellular, which is 25 liters. And out of the remaining 15 liters, which is 1/3 of the extracellular fluid, about 12 liters, which is 3/4 of 15 liters, is present in the interstitial fluid, and plasma is 3 liters. What is the full volume of the blood? 5 liters. And 3 liters is plasma, and so what is the 2 liters?
Protein.
The cells. No. Plasma is the fluid. Fluid is 3 liters. Plasma is 3 liters. What is the remaining 2 liters? Total blood, 5 liters. The red blood cells, white blood cells, platelets, and of course plasma proteins also, but mainly plasma proteins are part of the plasma. Mainly the cells. So this all is like, so when it comes to the fluid, 40 liters total, 25 liters within the cell, 12 liters in the interstitial compartment, and 3 liters in the plasma. Now it's a very interesting thing. The fluid can easily interchange between these compartments, especially the tissue, the cells, and even the plasma. I give you an example. A person had an accident. He started bleeding. Where is the fluid being lost from? Which compartment is losing the fluid now?
Plasma.
The plasma, very good. So the volume of the plasma is decreasing now. The person has an injury, and then there is a blood is going on. This volume is decreasing now, gradually. He is going towards hypovolemia, isn't it? And if he goes into hypovolemia, we will study that in the 3rd lecture. He can undergo a hypovolemic shock. There will be profusion to all the organs will reduce, the kidneys are going to fail, liver will fail, and this is called multi-organ system failure. But in order to prevent that, what happens is plasma, the blood vessel quickly borrows the fluid from the interstitial fluid. So interstitial fluid starts giving fluid to the plasma so that maintain the 3-liter thingy, otherwise the person's going to die. And the interstitial fluid gets it from the cells. So as we are losing blood in case of an accident, our cells are dehydrating. Why they are dehydrating? Because they are giving fluid to the interstitial compartment, and interstitial compartment is giving fluid to the plasma, which has to be maintained around 3 liters, otherwise we'll go into hypovolemia. And this guy now, so the transfer of the fluid goes from here to here and then here. Okay, now the person reached in time to the hospital. They quickly, applied pressure and everything, they stopped the bleeding, they maintained the IV lines, and they quickly start. If the blood loss is too much, they can transfuse blood, but most of the time they're going to give lots of fluid, like 1, 2, 3 liters of the sometimes normal saline. So it's called ringer lactate, dextrose saline. Yes.
The person is not that great, their catheter.
Yeah, the catheter for what?
They're not that, they're getting good liquids in place in such large amounts.
Yeah, of course. It depends upon his Glasgow Coma scale, how conscious he is, how the situation is. If the guy has a bleeding and we know that he's lost blood but he's conscious, he can walk as well, then intervention can also give infection.
From the car crash.
Yes. Done only, depending upon a car crash, or even you get out from the cycle, a sharp thing that cuts your. The other day, one of our colleagues, he had an injury over here. He just slipped and it hit within the house, hit the corner of the table or something, and there was a massive bleed. But he was conscious. We never catheterized him in the ER. I was with him in the ER for the whole 8 hours. We never catheterized him because he was conscious. But if the person is like in an accident and he's semi-conscious, he's unconscious, of course we give the catheter straight away. But with regard to this, now when we have the catheters, the cannulas, and we start giving the fluid, which compartment is receiving the fluid? Again plasma, because it's in the blood vessel. Now, plasma start to get the fluid. The volume of the fluid in the plasma is now increasing the 3-liter thing. What will plasma do? It will start paying it back to the interstitial fluid. Okay, please, thank you very much. I borrowed it from you. This is your fluid. And interstitial fluid will ultimately give it back to the cells. Once all these fluids are in the equilibrium where they should be, then comes what you just mentioned, that you start to urinate the excess of the fluids which have been given to you. Unless a patient is a cardiac patient, then we are very careful how much fluid we have to give. We can go into cardiac failure. But for a normal person, whatever excessive you've done will go out from the form of urine. So this is what I mean, that they can exchange the fluid between themselves. Okay, so this movement from the blood vessel to the interstitial space is mainly controlled by 2 pressures. You have already studied that in inflammation. One is your hydrostatic pressure, which is capillary blood pressure. What does that do? It pushes the fluid out of the blood vessel into the interstitium. The other one, and this is usually at the arteriolar end of the capillary. The other one, at the venous end of the capillary, is the plasma colloidal osmotic pressure, which is because of the plasma proteins. What does that do? It tries to pull the fluid back into the blood vessel, and these 2 are the most important ones. Have a look at this. This is a very important picture to understand this concept. This is your capillary. This is the arterial end. This is why it is red, because this is supposed to be the oxygenated blood. And this is your venous end. Now, of course, in the whole capillary there will be hydrostatic pressure and there will be plasma colloidal osmotic pressure, and they are in tawazun. Okay? Now what happens is that once the heart pumps the blood towards the arteries and then the arterioles and then the arterial end of the capillary, the hydrostatic pressure is increased on this end because of the pressure from the heart. Got it? Now when at this end the pressure increases, it becomes more than the plasma colloidal osmotic pressure, so the fluid is pushed out into the interstitial space. With this fluid, do you ever know that the blood vessels have small branches entering into the nucleus or mitochondria of the cells? Does it happen like that? No, they don't enter into the cells. They are near the cells, and because of this hydrostatic pressure, the oxygen and the glucose goes out in the interstitial space, from where the cells exchange the gas, take the oxygen, take glucose, do the glycolysis, make ATP. Then in the same fluid, they give out carbon dioxide and the waste. And that carbon dioxide and the waste at the venous end, what happens, this hydrostatic pressure starts to become less, isn't it? And this plasma colloidal osmotic pressure is now bigger than the hydrostatic pressure at the venous end. Got it? And what will happen then? It is going to pull the fluid back into the capillary. And then from the vein, it will go back towards the heart and the lung and the kidneys to excrete and everything. Yes?
Okay, the colloid pressure, right? It's dictated by the proteins in the cytoplasm, right? Why is there like high colloid pressure in the arterial gland?
There is, yeah, that's what I'm saying. That's what I'm saying. Remember. Imagine both of them are together. Both of them are balanced. Imagine this is like in the middle. You see here? They're balanced or not? They're balanced. When the blood comes from the heart, at the arteriolar and the hydrostatic pressure becomes bigger than plasma colloidal osmotic pressure because of the pressure generated from the heart. That's why at this end, this pressure will cause the fluid to go out. But as this blood reaches the venous end, their hydrostatic pressure is gone down. And at that end, the plasma colloidal osmotic pressure is now bigger compared to the hydrostatic pressure. And then it sucks the fluid back up. Yes?
The osmotic pressure is constant, right? It doesn't change.
Yeah, it's kind of, it changes. It's not constant. It changes. It changes gradually in relation to this. Because as the pressure at the arteriolar end it's just like in the arteries you have more pressure, in the veins you have less. And that pressure is the hydrostatic pressure.
I meant the osmotic pressure.
Yeah, the plasma colloidal osmotic pressure, yeah, it's because of the plasma proteins. Yes, it kind of remains constant, exactly. Yes. Yeah. Okay, now whatever fluid, so imagine, fluid goes out, fluid comes back in, some little fluid can remain here, isn't it? That fluid is taken up by the lymphatics, and if the lymphatics take it to somewhere else, we will start to have hypovolemia. Why? Every time some little fluid left in the interstitial space and lymphatics take it somewhere else, so the fluid will become less in the blood, isn't it? But actually, lymphatics bring it back to the circulation into the subclavian vein. So the fluid remains constant in the blood, isn't it? Goes out in the interstitial tissue, come back in, excessive through the lymphatics back into the circulation, so the total volume of the plasma in the blood remains constant, isn't it? Now, any factor, you tell me, any factor that leads to an increase in hydrostatic pressure, not just this is the normal scenario that because of the arterial pressure, there is more hydrostatic pressure. Any factor that increases the hydrostatic pressure, can that cause edema or not? Yes, because it's pushed from the blood vessel into the interstitial space. On this side, any factor that will reduce your plasma colloidal osmotic pressure, can that cause edema or not? Yes, because as the plasma colloidal osmotic pressure becomes reduced, it will not be able to get the fluid back into the venous end of the capillaries. So remember this. Now, two factors are increased hydrostatic pressure, decreased plasma colloidal osmotic pressure. They can cause edema. Lymphatic obstruction. If the lymphatics are obstructed, can they be able to take excessive fluid back in? No, then there will be edema. Renal diseases. If you have a renal disease, then the kidneys do not excrete the salt. Once they can't excrete the salt, automatically the renin-angiotensin-aldosterone system becomes activated, and that aldosterone leads to further reabsorption of the salts as well as water from the tubules. So it is not secreted in the urine, so where does it go? Back into the blood. And this ultimately leads to increase in the blood volume. When blood volume increases, the hydrostatic pressure increases or decreases? Increases. If it increases, it can lead to edema. Similarly, antidiuretic hormone. Diuresis means release of the fluid in the urine. But antidiuretic hormone, what does that do? It reabsorbs that water from the tubules and back in towards the circulation, again increasing the hydrostatic pressure. And then finally, urine inflammation. Vasodilatation leading to the increased hydrostatic pressure, remember? And then the increased vascular permeability leading everything to go out. And as and in this case, with increased vascular permeability, the plasma colloidal osmotic pressure is disturbed because the plasma proteins go out. Plasma colloidal osmotic pressure already becomes. So, vasodilatation causes increased hydrostatic pressure, and increased vascular permeability causes decrease in the plasma colloidal osmotic pressure because the proteins go out into the interstitium from the blood vessel because there is gaps now between the endothelial cells. All these factors we'll do one by one. See, increased hydrostatic pressure can be generalized, like everywhere in the body, every tissue of the body, the hydrostatic pressure is increased. Guys, make your attendance second and now. So everywhere in the body, every tissue of the body, the hydrostatic pressure is increased, and that is called generalized increase in the hydrostatic pressure, or generalized edema. And when it is to do with only one tissue, that in one tissue the hydrostatic pressure has increased, then that is called localized increase in hydrostatic pressure and localized edema. I give you example, when do we have generalized and when do we have localized? Generalized is congestive cardiac failure. Your heart pumps like this. And in one beat, in one pump, at the same time, heart, left ventricle pumps the blood in all parts of the body. At the same time, blood from the lungs come into the left heart, in the left ventricle. At the same time, from the right ventricle, the blood goes to the pulmonary as well as lungs. And at the same time, from all the tissues, the superior vena cava, inferior vena cava blood enters into the right side of the heart. This all happens in one go. This goes this comes here, this goes this comes here, isn't it? Now, if the heart has failed, it's not able to pump. Will it be empty or will it be full of blood? Full of blood. Can the blood from the different parts of the body, which is of course the venous blood, returning back to the heart, can it return back now? No, it cannot enter. So where will it go? Remain in the tissues. So what will happen to the hydrostatic pressure in the tissues? Increase. Because the fluid is not getting back to the heart, it is remaining in the tissues. So if the volume of the blood increases in the tissues, the hydrostatic pressure increases because of the volume of the blood. This time not because of the pressure, but because of the volume of the blood. And as a result of this, you will have edema. And where is it happening? Everywhere in the body. Because the heart has failed, all the tissues will not be able to send the blood back, and there's going to be generalized edema. And then constrictive pericarditis. Pericarditis is inflammation of the outer membrane of the heart. Sometimes it is this membrane becomes so thick and calcified because of inflammation that it does not let the heart to pump properly. In that case, there will be generalized edema, but at least heart is somehow pumping, so the amount of generalized edema in this one is going to be a little less than the congestive heart failure. Similarly, renal failure. When the kidneys fail, they lead to, as I just told you, excessive reabsorption of salt and the water, increase the blood volume, and this blood volume is not just increased for one organ, for all the organs. And then they have generalized edema. The hydrostatic pressure increases because of increased blood volume, because kidney is absorbing a lot of fluid compared to excreting it, because it's diseased now. A lot of time we diagnose the renal issues of the patient by just having a general physical examination and the patient himself saying, "Doctor, I feel some swelling on my body." And when the doctor examines, you could feel that this swelling is like generalized. So then he writes down the renal function test, the urinary, and you may see in the urine the proteins are there, and in the creatinine, which is the renal function, one of the proteins for the renal function, creatinine is increased in the blood because the kidneys are excreting it, and that's how you recognize, oh, there's something wrong going on with the kidney. So this is generalized, and increased hydrostatic pressure causing generalized edema. Localized, a tissue, its vein brings the blood back towards the heart. If the vein becomes blocked, what will happen? Then as a result of this, that vein can block because of the thrombosis, or it can go because of a neoplastic mass. Mass compresses the vein. Does the fluid go back now? No. It will remain in that tissue, and that tissue only will have increase in your hydrostatic pressure and will cause a localized edema. Similarly, in inflammation, if inflammation is occurring in this arm, I will only have swelling in this arm, edema in this arm. Why? Because of that, in that case, it is increased vasodilatation, causing more blood to come in. Here, the blood is not going out. In that case, more blood is coming in because of the vasodilatation due to the mediators, isn't it? And then there is the localized edema in my hand only, because this is where the inflammation was taking place. So that's localized. And then prolonged dependency. Dependency means something hanging. If all day I don't raise my hands are like this, they will start to have edema. Traveling on an airplane. Flight from Jeddah to Los Angeles is 16 hours. You get onto that flight, it's a long flight. They tell you always keep doing like that, sitting on your seats on the long flights, or go for a walk. Even the pilots go for a walk. one by one. So, why? Because when we walk, when we do this, we get our muscles contracted, the venous pumps start working, and the venous return back to the heart is improved. Now, sometimes happens to me as well. When I reach on my seat, I often take off my shoes, put them on the side. I have these travel socks, I put them on, and I just lie down. Sometimes I'm so tired, I don't even realize the plane has taken off. I'm asleep. And sometimes, often I'm on the window side. I like to stay on the window side. I can, track the airplanes, some of them crossing, and it's easy to just put the pillow here and sleep. And then I say, okay, I don't want to disturb these next fellows going to the toilet. I'll probably go to the toilet once only, So, after like 4 or 5 hours, I feel that now I have to go to the toilet. So, I start to put on my shoes. The same shoes which I put off. Now I feel they're feeling tight. The shoes didn't shrink. My feet were in the dependence position. I didn't use them for 4 hours. I'm sleeping, just my legs lying down there. The venous return is reduced. As a result, from where it is reduced? Not from the other parts of the body. From the dependent parts. From the gravity is pulling them down. And we are not using our pumps to bring them back. So there will be edema in my feet. As soon as I start moving, and starts to get better because it's going to bring the fluid back into the heart. So these things actually are present in your normal life. Reduced plasma colloidal osmotic pressure. Okay, see, for the plasma colloidal osmotic pressure, it's important we have plasma proteins, isn't it? We will have plasma proteins. When we eat proteins, then the digestive system gives amino acid that reaches the liver to make proteins. We need functioning liver to make proteins. And does the kidneys normally excrete proteins? No, it's not their job. If they start excreting proteins, they're diseased. So nephrotic syndrome is one of the syndromes in which the plasma proteins are being produced perfectly fine by liver, but the kidney is excreting them in the urine. So you tell me, plasma colloidal osmotic pressure decrease or increase? Decrease, because from the blood, you are losing proteins through the kidney. Okay. Second, kidneys are fine. No problem with the kidneys. But the factory that is supposed to make the plasma proteins, your liver, it's receiving amino acids from the digestive system also, but it's not functioning. Liver cirrhosis, fibrotic liver. The enzymes of liver are raised. The liver function trends are deranged. The liver is failing. Alcoholic cirrhosis, hepatitis B, C induced cirrhosis. And then you don't have plasma proteins or lack of plasma proteins, and there is lack of plasma colloidal osmotic pressure. That's why people with liver failure have ascites. Fluid enters into the peritoneal cavity because the plasma colloidal osmotic pressure in the blood vessels is less, so they often have it in their abdomen. Okay, then, no problem with kidneys, no problem with the liver. Liver is producing proteins perfectly fine. Kidneys are not excreting them out, but we are not eating proteins. If we don't eat proteins, where will be the amino acids come from? How will amino acids reach the liver from the, across the digestive system? The lack of proteins we eat, the lack of amino acids reach the liver, the lack of plasma proteins will be formed.
Liver cirrhosis aside, would it be considered localized or
No, normally it can happen in other parts of the body as well, but somehow in liver cirrhosis, because liver is in the abdomen, so mostly it's in the abdominal vessels that excrete out the fluid, and the two layers between the peritoneum and the peritoneal cavity, that's where the fluid accumulates. Ascites is, you can say, a localized edema which is called hydroperitoneum, and that is associated with liver cirrhosis. But this is mainly ascites. People can have this, like pregnant ladies.
Yeah.
People can have these much big tummies. And then we taught you in medical terminology, paracentesis, abdominocentesis. We put a needle and we drain it. But again, where does this fluid come from? From the plasma. So what we do, and the lymphatics there are trying to take this back. Lymphatics are working to bring this fluid back into the circulation. So when we remove it, we don't remove it like we start giving intravenous fluids from the top, and we start removing it from there, so there is no imbalance in the fluid. You see my point?
And when would I be given fluid or platelets or platelets?
Yeah, that's a different talk. That's a different talk. This is after we do the CBC, complete blood count. In the complete blood count, we see hemoglobin is less, that means RBCs are less. If we say the platelet count is low, the person is bleeding because of somewhere, then we give him platelets only. Sometimes we give red cell concentrate only. Sometimes we give the whole blood. Sometimes we only give the fluid. So this is a more clinical thing in the ER and everything. So let's focus here. I already came late. So let's focus this. Okay. Then you're not eating anything, malnutrition. It will also reduce plasma colloidal osmotic. And then finally, you're eating good proteins. Liver is making good proteins. Kidneys are not excreting proteins. But what is happening is either the proteins are not being broken down properly by the digestive system to make amino acids, or the amino acids from the intestinal villi are not being absorbed into the circulation. This is called gastroenteropathy, protein losing gastroenteropathy, a disease in the gastrointestinal system where the protein is lost in the wastes, whatever protein you eat. So ultimately, less amino acids or no amino acid reach the liver. Will there be plasma proteins? No. So then you have reduced plasma colloidal osmotic pressure. Lymphatic obstruction. Anything that can cause obstruction in the lymphatics. It could be lymphangitis, inflammation of the lymphatic vessels. Neoplasia, a tumor, post-surgical, after the surgery. And sometimes we damage the lymphatic vessels, they block post-irradiation. Like for the breast cancer, we told you we give radiation therapy to the patients after that. So the area where you're focusing with the radiation to kill the cancer cells, sometimes this radiation also leads to damage in the lymphatics. And the lymphatics become blocked, and then you have this edema. Okay. Sodium retention. If a person has renal insufficiency, they're restricted with the salt. The people whose kidneys are not working, because if they take excessive salt, more salt is absorbed from the kidneys into the blood, and as more salt is absorbed, automatically more water is absorbed as well, and as a result of that, you can have increased hydrostatic pressure ultimately through the renal angiotensin aldosterone system. And finally, inflammation. We already discussed that. This is an important figure. It summarizes everything I've been talking in the previous slides. Heart fails. Automatically, the venous return is compromised, so increased capillary hydrostatic pressure. You agree with me? Causing edema. Heart fails. Does the parts of the body will receive proper blood if the heart fails? No. So when the kidney receives less blood, kidney thinks, oops, it looks like the volume of the blood is less. That's why I'm receiving less blood. What can I do for it? It will say, okay, I'm going to absorb more water from the whatever blood I'm receiving, and absorb more water. So ultimately, renal angiotensin aldosterone system becomes activated. It leads to more sodium retention, absorption, and water. It increases the blood volume, causing edema. Correct? Similarly, when the kidneys fail, they lead to more sodium and water absorption, and as a result, blood volume increases, and you have generalized edema. And finally, you're not eating good proteins, liver is not making them, kidneys are excreting them, you have gastroenteropathy. All these will reduce in the formation of plasma proteins, and one of the most important proteins is your albumin. And this is the most important protein in making the plasma colloidal osmotic pressure. Once this production is reduced, or it is lost in the kidneys, through the kidneys in the urine, this pressure decreases, you will have it. We do them all one by one, as I just informed you earlier. This one slide, I described everything in detail, and now we are going to revise that again. So, localized edema, when you have a tissue whose venous output is impaired, and that can be because of the thrombosis. What is thrombosis? We discussed in tomorrow's lecture. A clot within the blood vessel that blocks it. So if the clot is in the vein wing, it will not let the blood flow go out of the tissue, and then it will lead to the edema in the distal portion of the leg. Generalized edema, as I told you, heart failure, renal failure, it increases the hydrostatic pressure everywhere, and as a result of this, you have the generalized edema. So increased hydrostatic pressure, whether it's generalized or localized, it forces the fluid out of the blood vessel into the interstitial space, hence causing edema. Yes?
By systemic overload,
Yeah, systemic overload means increase in the blood volume. This is called pitting edema. Pit. Pit means small cavity. This is something we do to check edema in the patient. You see this ankle? Just above the ankle, today do this experiment. Press hard with your thumb. Keep it there for like 10-15 seconds, and then you leave it. You will see, you will also have a small pit, which will go back within like maybe 5, 6, 10 seconds. The skin comes back to normal. Anything you press will be pressed, but then it comes out normal. But in patients who have edema, when we press, it is so nice to press, it's so soft to go in because there is fluid in there. They have a bigger pit than you will have. and their pit will remain there for much more longer time than yours. It will take much longer time to come back into the normal place. So this is what we do to check edema in patients, and this is called pitting edema. And this is usually for the generalized edema. This is a test for the generalized edema, unless there is something wrong with the leg and there is edema in the leg. See my point? But this test we use to see if a person has generalized edema, he'll definitely have edema here. Okay, reduced plasma clot osmotic pressure, as I told you, you're losing proteins from the kidney, nephrotic syndrome, your liver's not producing it, cirrhosis, you're not eating good proteins, malnutrition. All these reduce the plasma clot osmotic pressure. As a result, the movement of the fluid is towards the outer side from the hydrostatic pressure and not coming back in. So what that do? You tell me, if the fluid is not getting back into the blood volume will increase or decrease? So the first effect of reduced plasma clot osmotic pressure is that it cannot let already you have fluid in the interstitial compartment, it will not bring it back. Once it does not bring it back, the fluid volume in the blood will reduce, isn't it? This reduction in the volume when it reaches the kidney reacts to this hypoperfusion, and it is going to retain the salts and water, and it will then now in reflex increase the volume of the blood. You're getting my point? And it will make edema bigger and bigger. Why? Because there is edema, there is already fluid in the interstitial space, cannot come back in. As a result, fluid volume reduces, and when it reaches the kidney absorbs more water, increases blood volume. When it increases blood volume, increases hydrostatic pressure, more interstitial fluid, but it's not coming back in. So edema is going to exacerbate. So this is what happens in this reduced plasma clot osmosis. Nephrotic obstruction, I told you already, they will not be able to take the fluid back. Sodium retention often occurs in patients who have renal insufficiency, whose kidneys are not functioning properly and they are taking excessive salt. So there will be more reabsorption of salt and water. And finally, inflammation, vasodilation, increased hydrostatic pressure, and increased vascular permeability, reducing the plasma clot osmotic pressure, and they can lead to edema. This we have done in the inflammation. Don't want to repeat that. Transudate form because of increased dilatation, transudate form because of increased vascular permeability. We can do that later. Now, the next one is hyperemia and congestion. Hyperemia, increase in the volume of the blood. Hyperemia is red, congestion is blue. What is the difference between the two? What do you think? Yes, in hyperemia there is oxygenated blood which is more. In congestion is the deoxygenated blood that is more. Both of them lead to increased volume of blood in the tissue. Now the same thing for edema. Remember localized edema? I told you it could be when the artery dilates, more blood comes in, increased hydrostatic pressure, isn't it? That is hyperemia when artery dilates. And vein obstructed, increased volume of the blood in the tissue, causing edema. But this time, which kind of blood? Oxygenated, deoxygenated? Deoxygenated, so it's congestion. In both cases, the amount of blood within the tissue is increased. But the type is different. So in hyperemia is an active process. It is associated with arteriolar dilatation. So when the arteries dilate, more oxygenated blood comes in. Often occurs when you have inflammation or exercise. Chemical mediators are released. When we are exercising or something, don't you see we flush? We become red. Of course we are swelling, but we become red. Why? Because of the chemical mediators secreted that cause vasodilatation, causing more influx of the arterial oxygenated blood into the tissues and leading them to look red and hot because of the engorgement of the oxygenated blood. Congestion, passive process, backward process. There is a blockage in the venous return, so backward flow of the blood to the heart is affected. So within the tissue you have more blood, which is the deoxygenated blood. This can happen when the cardiac heart fails. This can happen when there is a localized venous obstruction. All these will lead to, of course, edema, but congestion in case of venous obstruction, but hyperemia in case of the arteriolar dilatation. Have a look at this. This is normal. Is there any dilatation here? Is there any obstruction there? No, everything is normal. Hydrostatic pressure leading the fluid to go out, cells use it, waste coming outside, plasma osmotic pressure gets it back in, going like that. In hyperemia, you have increased, remember like in the inflammation, the mediator is causing the arterial dilatation. Can you see that? more blood comes in, there is more blood in the tissue, which blood? That oxygenated blood. So it is red here. The tissue is red. Then, in case of the congestion, is there any arterial dilatation? No. But the problem is here. Either there is a thrombus here or the neoplasia which is blocking it, or the heart has failed. It's not going out. So there will be more fluid, more blood in the tissue, but it is deoxygenated blood, so this is called your congestion. So, blood, when it comes from the heart, has more pressure, it is warm and oxygenated. As the blood flows through the tissues, the capillaries, it becomes deoxygenated, and also it loses its heat. The heat is from the arterial blood. When we do like this, it's the arterioles which dilate and bring the oxygenated arterial blood that makes our hands warm. So the tissue that has hyperemia will be warm. The tissue that has congestion will be relatively cold. It does not mean that that is 50 degrees Celsius like Saudi Arabia and the other one is in minus like Canada or Norway. No, no, no. Relative to each other, arterial blood is warm, the venous blood is cold. So remember, the hyperemia and congestion both have more amount of blood in the tissue. In the hyperemia active process, more oxygenated blood, the tissue is red, the tissue is warm. In congestion, more deoxygenated blood, tissue is blue, and tissue has deoxygenated blood. This is hyperemia. Maybe an allergy, maybe an inflammation because of bite of any kind of insect. You have an inflammation in this area. You see the redness? It's because of the dilatation from the histamine and the mediators. Look at the cyanosis, which is because of congestion. Cyanosis is a sign of congestion. You see blue lips? See the blue tips there? This is congestion. And these are going to be cold. These lips and this is going to be cold compared to the normal lips and the normal fingers. Now we come to hemorrhage. Okay, where is the blood contained in our body? Contained. Of course, it's going to all tissues. Only blood vessels? The heart. Both. Heart and blood vessels are a closed system. The blood is circulating in them. Yes, exchange is happening, but the blood is between them. So whenever there is remember the tumor cells enter into vasa, blood vessel. Intravasation, when tumor cells enter into the blood vessel during metastasis, is called intravasation. When they are going to make the secondary home, they exit the blood vessel called extravasation. So whenever blood extravasates from the blood vessel or the heart into the interstitial space or the extravascular space, this is called hemorrhage. Hemorrhage can be external, I got a cut and then bleeding is happening. It can be internal, somebody hit me in the abdomen and I say, okay, there's pain, but then I say, okay, it's getting better. The pain is because of the, he hit him in the muscle. Maybe there is a blood vessel in one of the viscera, one of the organs is damaged. And the bleeding is occurring and collecting in the peritoneal cavity, hemoperitoneum. And that is going to be internal hemorrhage. You're not seeing the blood coming out, but there is an internal bleeding. This is also called hematoma. We'll discuss that now. The smallest of the hemorrhages is called petechiae. The smallest hemorrhage. Petechiae are 1 to 2 millimeters. See this? This is almost only 1 centimeter. This much. This much is 1 centimeter. In 1 centimeter, you have 100 millimeters. And this one is only 1 to 2 millimeters. It's just like take your pen, on a piece of paper, start putting dots. Small dots. These are so minute. This is not minute. This is minute. Means very small. Very small hemorrhages occurring in the skin, mucous membranes, and the cerebral surfaces. Have a look at this. Can you see those dots? Red dots? These are petechiae. In the white matter of the brain. Look at this. This is the colonic mucosa. Within the colon, you have these red dots. These are petechiae. When we will have these very small hemorrhages? Number 1, when your platelet count is low. Number 2, yes, platelet count is okay, but the platelets are defective. They're not functioning well. Number 3, you have deficiency of the clotting factors. Often in case of people who are liver is not functioning well, liver produces the clotting factor which are the proteins. So this is your, this leads to your petechiae. Then purpura. Purpura are slightly bigger than the petechiae. They occur in the trauma and vasculitis. Have a look at this. Can you see these? Aren't they bigger than the petechiae? They're also like round dots, but they're far bigger compared to the petechiae. They occur in the trauma and vasculitis. And finally, ecchymosis or bruises. We all know them very well. They are 1 to 2 centimeters or greater than that. Have a look at this. Remember this? So it's very common. I'm giving you a lecture, I'm walking by, there is a pointed thing, it hits me here. I say, oh, okay, I give the lecture, I go back home, I'm taking a shower and say, oh, what's this? And then I remember, oh, there is a big bruise because I hit it there. When I had this hit, it broke down my capillaries, bleed comes out, the blood is going where? In the interstitial tissue, in the subcutaneous tissue. And that is internal or external? Internal, it's not revealed, it's not come out. And this is your bruise. This guy had a massive injury to the knee, and can you see? This is big, big bruise. Now, hematoma is when you have a blood that is collected in a closed space, internal bleeding, and it is located in a closed space. For example, hemothorax, like I told you, accident. Where is it accumulating? In the thoracic cavity, and it's not. Hemoperitoneum, within your peritoneum. And then hemarthrosis, in this case, I'm sure such a big injury, it will not only be this bruise in the soft tissue which you see. Of course, when it hit, all the capillaries of the soft tissue, they rupture, and within the subcutaneous tissue, interstitial tissue, now you have the bleeding. But along with this, he will probably be having bleeding within the cavity of the knee joint. And this is called hemarthrosis. Arthro, joint. So this is another thing where you can have the hemorrhage collected. So whenever you have a hemorrhage, which is the bleeding which is confined in a closed area, we call it as the hematoma. This is the last slide. Look at this. What tissue is this? Brain, very good. And what do you think are these silver things here which we have cut? Dura matter, very good. Now you tell me, this dura was up there, and we cut it and we see this hemorrhage. Is it under the dura or above the dura?
Under.
Under the dura, exactly. Subdural, which is this closed cavity in which this bleeding is confined. The space between the brain tissue and the dura. So this is subdural hematoma. Now we will probably remove it surgically. What is epidural? Which is above the dura and the cranium, in that closed space. So you see, this bleeding is not revealed, it's concealed, it's hidden, but within a cavity. So this is your subdural hematoma. Okay, thank you so much. Tomorrow's